Welcome back. Here is the continuation of our lecture about neonatal therapeutic hypothermia based on AAP Clinical Report 2026. The neuroimaging delay, finding the sweet spot. Moving forward from pharmacological management, let's address the critical nuances of post-warming diagnostics. When scheduling magnetic resonance imaging, timing is absolutely everything. We must understand a phenomenon known as pseudonormalization on diffusion-weighted imaging, or DWI, in a typical, non-cooled neonate with brain injury. Cellular swelling subsides and DWI pseudonormalization occurs quickly, typically at 5 to 7 days. This can prematurely mask the true extent of tissue damage on the skin. However, therapeutic hypothermia fundamentally alters this timeline, delaying pseudonormalization to 8 to 12 days. Because of this protective shift, the optimal MRI window, our absolute diagnostic sweet spot, opens on days 4 and 5. Brain imaging must be performed as soon as possible after rewarming or within this first week. This allows for an accurate, optimal classification of injury before delayed pseudonormalization can step in and obscure the underlying pathology. While our immediate focus is clinical and physiological, an effective neural rescue protocol cannot exist in a vacuum. We must deploy trauma-informed family integration, structuring our care in concentric circles that wrap around the neonate. At the outer layer, communication is paramount. An unexpected NICU admission is deeply traumatic for parents. We must mitigate this profound grief by strictly using clear lay language, providing easy-to-digest written materials, and maintaining perfectly consistent messaging from every single member of the healthcare staff. Moving closer to the center, physical contact is not only safe, but actively encouraged. Parents can, and should, hold their infants even while the babies remain on their active cooling blankets. Finally, let's talk about nutrition. For hemodynamically stable infants, low-volume, early trophic enteral feeds are completely safe. Integrating early nutrition and physical bonding has been proven to significantly improve long-term breastfeeding rates and shorten overall hospital stays. Beyond the NICU, long-term follow-up. A crucial takeaway for every clinician in this room, the protocol does not end at hospital discharge. Despite our best efforts and excellent execution, 29% to 40% of cooled infants will still experience mortality or long-term neurodevelopmental disability. Because of this reality, meticulous longitudinal tracking is mandatory. Upon discharge, the care plan branches into 3 essential pathways. First, immediate referral to early intervention services to maximize neuroplasticity. Second, dedicated monitoring through developmental pediatrics, with specialist visits precisely calibrated to the severity of the initial MRI findings and any ongoing feeding needs. And third, coordination with the primary care provider, who must be equipped with accelerated, clear referral pathways to flag and catch emerging developmental delays early. Long-term follow-up is our safety net. To conclude this lecture, let us remember that therapeutic hypothermia is far more than just a temperature setting on a machine. It is a highly intricate, interconnected ecosystem built entirely around the vulnerable neonate at 33.5 degrees Celsius. As we have discussed, a successful outcome requires every single gear in this machine to turn perfectly in tandem, from rapid multidisciplinary triage and specialized servo transport, to continuous video EEG monitoring, optimal timing MRIs, precision pharmacy management, and trauma-informed family care. Ultimately, the cooling blanket itself can only preserve brain tissue if the surrounding hospital infrastructure is perfectly aligned to support it. By mastering this complete playbook, we can ensure that every infant receives the highest standard of neuroprotection. Thank you for watching.